Hello, my name is Dr. Ada Semek-Josefagic. I'm a consultant pediatric allergist at Leeds Children's Hospital. Today, it's my privilege to present you on the topic of updating pediatric allergy management in primary care. First of all, I will give you a background information about the prevalence of allergic disease worldwide and in the UK. Secondly, we will look into common conditions in primary care, such as food allergy, spontaneous urticaria, hay fever, and penicillin allergy. Lastly, I will talk about the referral acceptance criteria into our service and summarize at the end. Global prevalence of pediatric allergy is on significant rise over the last several decades. In particular, it is estimated that about 25% of children in the UK suffer with some kind of allergic disorder. Up to 16% of these children also have multiple allergic comorbidity. Put into the context, particularly within a Leeds CCG area, we have about 140,000 children who are between age 0 and 16, of which probably about 30,000 suffer with some kind of allergic disease. If we look into particularly food allergy, up to 5% of children in the UK are known to suffer with food allergy, and this is most common in children under the age of 5. Typical allergens are milk, egg, soy, peanut, and wheat. Fortunately, there is a high resolution rate of these allergies, with majority of them resolving by the age of 5 and 6. For the management of food allergy in primary care, the primary management strategy is, of course, avoidance. However, all patients do need access to emergency treatments such as non-sedating antihistamines for children older than 1, and also in case of history of anaphylaxis or coexistent asthma, all patients would need to be prescribed with adrenaline autoinjectors and trained. I will now focus in particular on milk allergy, which tends to be the most common presentation of food allergy for children under the age of 1. It is a difficult diagnosis to make. However, the key information is in the history, and a good history is almost 90% diagnostic of any food allergy or allergic disorder. So, for example, if we talk about an infant who has atopic eczema or reflux or any gastrointestinal disturbance symptoms such as loose mucousy stools or constipation or faltering growth, we are more likely to be looking into the case of non-Ig mediated cow's milk protein allergy, or also known as cow's milk protein intolerance. Typically, symptoms are delayed and they evolve over a period of hours up to several days, and can present with a chronic inflammation symptoms. These patients would require referral to community pediatrics team, as these are commissioned to deliver service under Leeds CCG agreement. However, on the other hand, if we look into the patient who has had symptoms that have started immediately within a matter of minutes or up to 2 hours after exposure to milk or dairy, where they may have developed hives, swelling, difficulty breathing, cough, wheeze, or vomiting symptoms, we are more likely looking into non-Ig-mediated food allergy. And these patients obviously would need to go on complete milk and dairy exclusion and would require urgent referral to pediatric allergy service. Moving on to the next most common food allergy that we encounter in children under the age of 5, we will talk about egg allergy. There are estimated about 900 children under the age of 5 in Leeds CCG area who suffer at any time with egg allergy, and about 2,800 of under 16s with egg allergy. The most common history is of developing immediate symptoms, typically erythema, urticaria, angioedema, with or without single vomit after first known exposure to egg white or lightly cooked eggs such as scrambled egg or omelette. Most of the children with egg allergy will have coexistent eczema, and it is quite common that egg allergic children also have multiple food allergies such as to the case of, for example, rapid onset urticaria, repetitive vomiting, or diarrhea symptoms, or more severe symptoms such as airway or breathing compromise, or cardiovascular symptoms such as floppiness, paleness, lethargy. We are talking more about moderate to severe case of egg allergy, and in this case, these would need referral to pediatric allergy service. Another common question that we get from primary care is regarding immunizations of egg allergic children. All children with egg allergy can receive MMR vaccination routinely in primary care setting. This advice has been in Green Book since 2007. All children with egg allergy can also receive nasal flu vaccination in primary care setting. And most of the children are fine to receive injectable intramuscular influenza vaccination in primary care setting, except the ones who have had history of severe anaphylaxis requiring admission to intensive care unit. Another exception is a yellow fever vaccine for travel. All patients with egg allergy would require referral to Paediatric Allergy Center for yellow fever vaccination. So if we look into the detail of egg allergy management in the primary care, most of egg allergic children, particularly with mild moderate allergic reaction history, can tolerate baked egg in their diets. And breastfeeding mothers can also continue breastfeeding babies, as there is a small amount of egg protein that does not affect egg allergic children. Baked egg tolerance is also a good prognostic sign for egg allergy resolution before the age of 5 or 6. And if you find out from the history that child is tolerant of baked egg in their diet, it is okay to advise to continue to consume baked egg at home while still avoiding raw egg and less cooked egg varieties. Most of the children who have baked egg tolerance, as I say, go on to develop complete tolerance by the age of 16. And if we find that children do not tolerate baked egg, that would necessitate referral to Paediatric Allergy Service. If you come across the child where baked egg tolerance is not known, it is correct to advise full avoidance until 12 months of age or first birthday, and then recommend cautious introduction of baked egg products at home. This would, for example, be a baked egg in a cake, biscuit, or a homemade or well-done Yorkshire pudding. Who needs to be referred? So children with moderate to severe reactions, such as cough, wheeze, any respiratory compromise, or signs of cardiovascular compromise would require referral. If there is a diagnostic uncertainty about the egg allergy presence, if there is a case of multiple food allergy where egg allergy coexists, for example, with peanut or milk allergy, and if there is also a case of severe eczema in a child who is eating egg in their diet. Also, children who have a reactivity to both baked egg and raw and lightly cooked egg forms, which is not resolving before the primary school age, should be referred to Paediatric Allergy Service. Adult onset egg allergy is quite rare, but if you come across adult cases with new onset egg allergy, these would also require referral to Adult Immunology Service. Moving on to the next topic, we will look into allergic rhinitis. First of all, allergic rhinitis is common presentation usually in school and sort of adolescent age children. It very rarely presents before the age of 3 to 5. You would initially have to rule out presence of infectious causes of rhinitis and also other non-allergic, non-infectious causes of rhinitis, such as gastroesophageal reflux, sort of exposure to tobacco smoke, etc. How to diagnose allergic rhinoconjunctivitis or hay fever in primary care? So we are looking into presence of 2 or more nasal symptoms, such as nasal congestion, rhinorrhea, sneezing or itching, with or without presence of eye symptoms. Based on this symptomatology and the timing of the symptoms, you can diagnose the trigger for allergic rhinoconjunctivitis. Access to specific IG measurements through ICE system, and you can request specific IG measurements to pollen, house dust mite, or pets. Please don't request common inhalant mix, because this does not provide additional information that would aid further management and avoidance advice. If we look at the simple sort of algorithm of how to treat allergic rhinoconjunctivitis in primary care, the mainstay of treatment is actually intranasal corticosteroids, because they target chronic inflammation. For milder and intermittent cases, it is okay to treat with oral antihistamines or topical antihistamines. However, if cases present with more severe persistent symptoms, a combination of intranasal corticosteroid and oral antihistamines is advisable. For those cases who do not respond, a combination of these with trial of montelukast as a leukotriene receptor inhibitor is also recommended. Primary avoidance is also a key. Seasonal ones where you are exposed to pollen or house dust mite, which is perennial allergen present in indoor environment. As an adjunct to the treatment, we also recommend using saline douching. And for the cases that don't respond, in specialist immunotherapy. The mainstay of treatment is intranasal corticosteroid use. This is superior to use of montelukast or oral antihistamines. Patients do need to take this regularly to feel benefits, as the optimum effects are only reached after 2 weeks of continuous treatment, and this needs to be emphasized. Intranasal corticosteroids are different. They are not all the same. There are differences in bioavailability, but also safety and cost. The preferred ones in pediatric age group are fluticasone furoate, fluticasone propionate, and mometasone furoate, known as Avamis, Flixonase, and Nasonex, or their bioequivalents. We do advise against the use of beclomethasone, which has a high systemic absorption rate. So, who needs referral to pediatric allergy clinic? Patients with seasonal allergic rhinoconjunctivitis who are not responding to optimum medical treatment, comprising of intranasal corticosteroid and oral antihistamine, or patients with perennial allergic rhinoconjunctivitis which have inadequate response to optimum treatment and where the easy to achieve. Moving on to the next topic, I will focus on spontaneous urticaria, which is a common referral query. It's characterized by development of hives and swellings, or both together, without identifiable trigger, such as food or allergen exposure. It is very important for a referrer to examine the child, although swelling may not be present at the time of assessment, or to look at the photographic evidence on mobile phones that parents might be showing to confirm that actually we are talking about urticaria and angioedema, and not just by simple discoid eczema or any other kind of erythematous blotchy rash. So the most common presentation in young children is of acute spontaneous urticaria, which is characterized by recurring swelling and hives that occur over a number of weeks, up to 6 weeks, for no apparent reason. A trigger for this is concurrent or past viral infection, which may have triggered immunological response, triggering mast cell discharge. It's important to reassure parents because often this is labeled as an allergic type condition, and parents do often worry and go down the route of food elimination due to advice being provided in emergency care setting or in primary care setting. It is a self-limited condition, and it is characterized by recurrent urticaria and hives that actually don't usually clear even between the doses of antihistamine, unlike food-triggered urticaria, which would normally respond within a few hours of a single dose of antihistamine. If we are facing a case of isolated angioedema, it is important to rule out hereditary angioedema, particularly if it is occurring recurrently, and in that case we would recommend a blood sample to be sent for C4 levels and C1 inhibitor levels. For cases where spontaneous urticaria is lasting for longer than 6 weeks, we tend to classify these into 2 main categories: physical or inducible urticarias or chronic spontaneous urticaria. Often we do have a combination of these 2 presentations within a single patient, so we can see, for example, spontaneous urticaria coexisting with cold or heat urticaria or cholinergic urticaria. The treatment is following this algorithm. For the primary care setting, we recommend treatment with second-generation non-sedating antihistamine starting from licensed doses once a day regularly until symptoms subside. And if symptoms continue to persist for several weeks, we would recommend updosing every 2 to 4 weeks to up to a maximum fourfold of what's normally recommended for that age group. At this stage, you should be thinking about referring to pediatric allergy clinic, particularly if there is a poor response to higher doses of antihistamine. We would consider then further increments up to fourfold if it's not already been done under primary care. And if there is a poor response to the treatment, usually within a few months we consider treatment with biological omalizumab. In most resistant troublesome cases, the next stage of treatment, if there is no response to omalizumab, is a trial on immunosuppressants such as cyclosporin. The next common presentation in primary care is penicillin allergy. It's known that up to 10% of population is labeled as penicillin allergic, and this figure is doubled among the inpatients in hospital. If you are encountering a patient where there is a family history of penicillin allergy, or if patient upon taking penicillin has previously had mild gastrointestinal symptoms such as vomiting or diarrhea, we are more talking about adverse effects, and therefore these cases should be given alternative penicillin, but do not require further investigation for penicillin, as this is not a penicillin allergy. For cases where children present with mild maculopapular rash or delayed onset urticaria and angioedema, often 2 to 3 days after initiation of treatment, we would consider this suitable as referral to pediatric allergy clinic. Most of the cases under the age of 5 actually turn out to be virally induced exanthemas and tolerate penicillin once challenged in hospital. And lastly, the cases who present with immediate onset rash, swelling, difficulty breathing, or other respiratory or cardiovascular symptoms do require further investigation assessment in pediatric allergy clinic to investigate and offer further alternatives. So within the Leeds Children's Hospital, we have set up a penicillin allergy delabeling clinic, which has been now running for 2 years. We normally see children with mild maculopapular rashes or delayed onset urticaria or angioedema symptoms occurring usually 2 to 3 days after initiation of treatment. And these children tend to have a single provocation to oral amoxicillin or any other culprit antibiotic to rule out or confirm their diagnosis of penicillin allergy. From our own data, we know that 95% of children go on to tolerate antibiotic without further issues and therefore are successfully delabeled. If you are looking into referring patients with similar history to the clinic, please provide information on distribution and timing of onset of symptoms, the generic name of antibiotic that has been used, number of doses that have been taken prior to the treatment, and also how long symptoms have lasted before settling. So I would like to talk about referral acceptance criteria in a bit more detail. Children who have a family history of, for example, nut allergy do not require investigation or testing for nut allergy themselves, as they haven't got personal history of already existing food allergy, or particularly if they don't have any other atopic conditions such as severe eczema. So any child who is otherwise fit and healthy without personal history of food allergy or severe eczema does not require further investigation, and family can be advised to wean child as normal. And this is also part of prevention of further sort of allergy pandemic and early weaning onto allergenic foods in order to stop allergy epidemics. Second scenario are children who are usually primary care with unexplained gut symptoms, typical abdominal pain, loose stools, diarrhea, constipation, where symptoms have presented beyond the infancy and there's no clear relationship with the food ingestion or exposure to food allergen. These children can be referred to community pediatrics or general pediatrics team, but do not require investigation for food allergy. And third common scenario are children with non-IgE mediated cow's milk protein allergy. These would require referral to community pediatric team who are commissioned to deliver service and care for these children. If we talk about inhalant allergy, we do not see children with pet allergies. The investigations for this can be done through the primary care, and also children who have mild, moderate symptoms of allergic rhinoconjunctivitis who are responding to the standard optimized treatment. As previously mentioned, the diagnostic tests are available to the primary care and can be easily accessed to ICE by requesting specific IgG measurements to individual suspected allergens. The third common presentation of eczema. If there is a child who presented with eczema, usually after the age of 2, they would not need a referral to pediatric allergy, as at this stage it would be very uncommon for eczema to be triggered by food allergen, and these children do require optimization of their treatment and referral to pediatric dermatology if there is concern about a poor response. If we look into the urticaria, as already mentioned, acute urticaria with or without angioedema, presentations particularly lasting for less than 6 weeks and occurring concurrently with viral infection, can be managed with regular non-sedating antihistamines through primary care and with reassurance of parents. Even if there is no identifiable viral infection that has concurrently occurred at the time, it is still possible to have acute spontaneous urticaria that has occurred for unknown reasons, which often from experience settles within less than 6 weeks. Other common referrals that are sent to pediatric allergy clinics are perioral skin reactions, often mild, after ingestion of tomatoes, berries and citrus fruit in a weaning age child. These can be managed with some optimized topical skincare regime, particularly if the child has dry, eczema-prone skin, and with advice that parents can retry these foods once the skin barrier has improved and once their eczema has settled. As previously mentioned, the family history of drug allergy, such as allergy to penicillins, without prior exposure or known reaction in an index patient, does not require a preemptive investigation, and the person can be prescribed a penicillin type antibiotic if required. Also, we do not need to see children who present with delayed onset large localized reactions after insect stings, such as to bee or wasp venom. And typically these will occur at the locality where the insect bite has occurred. The treatment here would be of comprising predominantly of some oral antihistamines, topical steroid ointments, or in severe cases if it's oral corticosteroids. So any child with immediate reaction to food that occurs typically within minutes or within an hour of exposure. Any child with immediate severe allergic reaction without clear cause, such as in cases of idiopathic anaphylaxis. Children who present with chronic urticaria that lasts for longer than 6 weeks and are not responding to standard treatment with licensed doses of non-sedating antihistamine. Children with allergic rhinoconjunctivitis that are not responding to optimized regular treatment, and cases of drug, insect allergy or latex allergy. So in summary, there is a lot of information that can be found on our referral criteria for pediatric allergy document available through Leeds Health Pathways. It's essential that prior to referral, the detailed allergy-focused history is taken and that management is optimized with oral non-sedating antihistamines and prescription of adrenaline auto-injector where indicated. And then also a key point that family history of atopy does not necessitate child's referral to pediatric allergy clinics. Thank you for listening.